again, thanks for coming. We really appreciate it. Hopefully this is a start of just a new relationship and new things being better here. And I'd like to introduce Dr. Brett Roberts from cardiology to give us his talk.
Okay. Okay, thanks everyone for coming out. So I'm a cardiologist. I specialize in electrophysiology, so this is the kind of stuff I love. Because I like it so much, if anybody at any point ever has any EKGs or anything interesting they don't understand or things that happen in the field, just bring it on in and they can get in touch with me and I'll be happy to review anything with you guys. Before we start, just like to thank Medtronic, who sponsored the Chinese food. I don't know if they're here or not, but thank you. All right, so we're going to talk about EKGs today and a little bit about electrophysiology. This is meant to be fun, okay? It's going to be, to some degree, interactive. And if anyone has any questions at any point, feel free to ask. If anyone has any questions to start before we go, feel free. Nothing. Okay. All right, so when you think about electrophysiology, you have to really think about a differential. What are all the things that can cause the EKG findings that we're seeing? What do people see in this picture? Does anyone see anything else? A rabbit, right. Does everyone see the rabbit? Right? You got the ears, and here's the mouth, and the eye here. So when you think about these things, you're always trying to figure out, what else can explain what you're seeing, okay? And the first thing that I always ask is, what does narrow complex tachycardia mean? Well, that one's very straightforward. Narrow complex tachycardia is a fast heart rhythm from the top chambers of the heart, okay? When I say SVT, that's different than narrow complex tachycardia, okay? SVT refers to three specific fast heart rhythms: atrial tachycardia, AV nodal reentry tachycardia, and ORT. SVT is not atrial fibrillation that's beating quickly. It's not atrial flutter, okay? And we'll go over this a little bit more throughout the talk. All right? And when we think about narrow complex tachycardias, there's things that can give you hints to the diagnosis when you see these patients. If the heart rate is 260 beats per minute, it's not sinus tachycardia. Nobody's heart can beat that quickly, okay? Generally, we use that thing 220 minus your age. So if an 80-year-old is going 210 beats per minute, it's not a sinus rhythm, okay? It's a different mechanism. So that right there off the bat is helpful, okay? Sinus tachycardia, if you're following the patient for a period of time, it doesn't just go from a heart rate of 90 to a heart rate of 200, okay? It's a gradual increase. So if you start seeing gradual increases in heart rates, think of sinus tachycardia. We'll go over this a little bit more, but AV nodal reentry tachycardia, we'll talk about. These are P waves that you'll see buried in the QRS. We all know about atrial flutter and that sawtooth pattern, and classically the heart rate is generally 150 beats per minute. Atrial fibrillation, erratic conduction, and atrial tachycardia can look like sinus tachycardia, but we'll talk a little bit more about these. Okay, so everyone, you're in the ambulance, you're driving to the hospital, all of a sudden you start seeing this. So what do we do here? Do we call a code? Do we begin CPR? Do we check a potassium and mag? Or do we say, it's nothing. Let's drink our coffee? What's everyone think? Any takers? So what do you guys, what is all this stuff here? Is this ventricular tachycardia? Right, okay. So the answer is keep drinking your coffee. And this is a very common thing that we see in the hospital. All the time we see patients and we get consults for this is ventricular tachycardia, and there's actually been a case series of patients who have gotten defibrillators for this rhythm. And what this is all artifact, okay? And the reason you know it's artifact is because you see this is the sinus beat here. I mean, this is the QRS, correct? March it out, right. You go through, there it is right there. There it is there. There it is right there. This one's a little bit hard to see, but you see it right here, right there, right there. So it's marching through. So you got to be very careful when you see these things that, a patient doesn't get shocked inappropriately. You don't defibrillate someone for this. Always keep that in the back of your mind. Anyone have any questions about that? And sometimes it will really, you'll see these huge waves, but you'll see it'll only be in one lead. You won't see it in the other leads. It can't be ventricular tachycardia or ventricular fibrillation if it's only in one lead. It's got to be in every single lead, okay? Okay, now remember, everything is always looking at differential diagnoses, and it's almost as important to rule things out as it is to rule things in, okay? So this is a 49-year-old with severe chest pain. Anyone want to comment on what they see here? Yeah, so you see ST elevations, you see it in 2, you see it a little bit in 3, you see it in AVF. But wait a minute, look, you see it in V4, V5, V6, you see it in lead 1. So if this is a STEMI, where is it coming from? It's in every lead. Yeah. So, you know, if someone had infarcted every single one of their coronary arteries, they'd be dead. They wouldn't be alive. So it obviously can't be that. So the answer to this one is give the patient some Motrin. This is pericarditis, okay? It's not something that you all see terribly frequently, but the hallmarks of pericarditis are you see PR depression, so the PR segment is depressed, okay? And you see diffuse ST elevations in almost all the leads, okay? You see it here, it's everywhere, okay? Not something you need to make the diagnosis in the field, but something to sort of consider. All right. Anyone have any questions about that? Make sense? All right. All right, next one. Patient complains of a little bit of shortness of breath. What do you guys think about this one? What's that? First degree. All right, so you see P waves, okay, and you see a long PR. That's a really long PR interval. That's 200, 400, 600, almost 800 milliseconds. That's really long. It's almost a second. So yes, it's possible. I have seen PR intervals this long. But remember, you always want to look at all the leads and go through everything. So does anyone else see anything else on here? I'll give you a hint. Look at lead 2. Well, there's clearly P waves, right? So this is a rhythm disturbance. Clearly P wave here, 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 here. Oh, what's that? P wave, right? So if you look closely, P wave here, one here, you can barely see it, one here, maybe one at the tail end of this QRS, one here, and there's one here in there, one here, 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 right? So it's really important when you see these bradyarrhythmias like this to look at all the leads, because you know in some of these leads you'd have no idea. You just say this is first degree AV block. Okay. So what is this actually? Third degree. Why is it third degree and not second degree type 2? Yeah. Correct. Correct. The PR segment, or there's no relationship between what's happening in the P waves compared to what's happening to the QRS. So to make it a little more advanced, can anyone tell me where the level of the block is? Meaning, so the sinus node is firing and producing the P wave, but at what point down the electrical highway is there disconnection? And the key to answering that is looking at the QRS, okay? Is the QRS narrow or wide? Narrow. So if it's narrow, that means it's going down both of the bundles, right? It's going down the left bundle and right bundle simultaneously because the heart is being depolarized both sides at the same time, and it makes it look narrow, okay? So if it's narrow and it's going down both bundles, where is the signal coming from that's depolarizing the bottom chamber? Because it's not coming from the top chamber, right? They're not talking. The junction, exactly. It's got to be coming from the junction. And that's an important thing when you see someone in the field. And I mean, when you see heart block, the next question you should ask, is it narrow or is it wide? Okay? The narrower that it is, the better the patient's going to do. Okay? The wider it is and the lower it is, the worse. The less reliable it is and the more likely that you're going to have to transcutaneously pace someone down the line. Okay? So you'll see a left bundle sometimes. And if it's a left bundle branch block, that means that the signal is coming from the right bundle. Right? Because the left bundle is blocked. It's coming down only the right bundle. Can't make it down. Sometimes you'll see going down the left bundle and you'll see a right bundle branch block. Okay? So that's always what I look at, to look at for stability. So third degree arc. Okay. What do you guys see in this one? I'll give you a minute to look at it. Second type 2? Why do you say that? Why isn't it complete heart block? Look, you've got all these P waves without a QRS. You're right, but tell me why. Right. So remember, the definition of complete heart block is that there's dissociation. The top chambers and the bottom chambers are not talking at all. Okay? If you notice, each of these QRSs that conduct, okay, the PR segment is always the same. Okay? So the distance from the start of the P wave to the QRS is the same. From here to here is the same from here to here. From here to here is the same from here to here. That can't possibly be coincidence if the bottom chamber is beating to its own drum. Correct? All right? So you'd call this second degree type 2. I mean, in essence, does it really matter if it's complete heart block or what we would call high degree AV block? Probably not. You treat the patient the same way, but just a little more entertaining. Okay, how about this one? Give you a minute to look at it. These are all rhythm problems, so we're not looking at the morphologies of the QRS. It's all about the relationships of the P waves to the QRSs. What do you got?
Second degree type 1.
That's right. Why?
You drop the QRS.
So, but if you drop a QRS, that could be Mobitz 2 as well. How do you make the distinction between Mobitz 1 and Mobitz 2?
PR gets smaller.
Right. Exactly. So if you look in lead 2, you see the PR segment is fairly short. Then it gets longer. Okay? You can't really see it here, but you can see it right there. Right? So here's a PR. PR gets a little bit longer. And then here's a P wave that drops. Right? The best way to figure out if something is Mobitz, when the PR segments are fairly close, it's kind of hard to tell if they're lengthening. The way I was always taught was the first one that conducts after a block, okay, so this one, this PR interval will always, always, always be shorter than the last one that conducted prior to the drop beat, okay? So if all you got to do is look at this one compared to this one. This one must be shorter than this one, okay?
Why does that happen?
Why does Wenckebach happen?
No, why does the interval get shorter after it's missed?
Oh, because this is a problem in the AV node, okay? It has to do with, this is not a problem with an actual conduction problem. This is from vagal tone, so high parasympathetic tone, okay? And it's, what happens is the AV node, when it gets bombarded with signals, okay, the AV node is like a toll booth, right? Its goal is to protect the bottom chambers from fast heart rhythms. So when you go into atrial fibrillation, and the top chambers are beating 500, 400 times a minute, that the bottom chambers don't beat 400 times a minute. So it has the electrophysiologic properties that the more you bombard the AV node, the slower it conducts. The slower it allows activity to go through it, and it's a safety mechanism. So here, it gets bombarded a little bit, so it gets a little bit longer. Here it blocks, so then as there's been a long time since it's gotten through the AV node, so then it becomes shorter again. It's more I have to draw these ladder diagrams to explain it, but that's essentially the concept. Okay, so when you get this call and you see this patient in this rhythm, do they need an urgent pacemaker? Do we put pacemakers in for Mobitz 1 heart block? Why not? What's that? Because again, it's the same concept. This is because of vagal input or parasympathetic activity into the AV node. There isn't a problem. These patients don't ever progress to complete heart block, okay? This can last forever, okay? And sometimes in well-conditioned athletes, you'll just see this rhythm, okay? Because they have such high parasympathetic tone, okay? So the answer is no. Okay. All right, now we're into a bit of a faster rhythm. So here we go. AV NRT, atrial fibrillation, atrial flutter, WPW, atrial tachycardia. I have no idea, leave me alone. So again, the easiest way to figure out what it is to figure out what it is not. Okay? So what things can you definitively say this is not by looking at this? Right, it's not AFib because it's regular, right? Can't 100% say it's not atrial flutter, okay? What about all these other things? Hard to say, right? Not WPW, correct, because it's, why? Because WPW is wide, right? When you see WPW, they have a wide QRS. This is a narrow QRS, so that's ruled out. So really you're down to atrial tachycardia and AV NRT. Okay, so what did we talk about? What do you usually see in atrial tachycardia? P waves. When you look in here, do you see any P waves? I mean, is that a P wave or is that a T wave? What is that? This is a T wave, right? I mean, that looks like a pretty common T wave. That doesn't look like a P wave. So when I look through here, I don't see any P waves. So pretty much rules out atrial tachycardia. So what this is AV nodal reentry tachycardia. Okay? And the key to AV nodal reentry tachycardia is there is actually a P wave, but the P wave comes after the QRS. Okay? And if you look, here's the P wave. This tiny little ditzel here. Okay? And one thing that you can do, if someone's an SVT in the field and you give them adenosine, okay, and it terminates the heart rate, what you should do is compare what the QRS morphology looks like after it terminates to when they're actually in the rhythm, okay? And if you see when they're in the fast rhythm, they have a little ditzel thing at the end of the QRS, and then when they're not in the fast heart rhythm, you no longer see that, okay? Think about AV NRT, okay? The best lead to see that in is V1, okay? Here you can see this little guy right here. All right, so does anyone have any idea what AV NRT is? Have you guys heard of AV NRT? So generally when we talk about SVT, okay, that's just a catch-all phrase, okay? SVT just means a fast heart rhythm from the top chamber, it's regular. But you know, it's important to figure out which, at least when I see the patients, about which of these fast heart rhythms it is, okay? And there's generally a couple mechanisms of how people get fast heart rhythms from the top chambers of the heart, okay? This is AV NRT, okay? And to best explain what AV NRT is, I like to think about the Baltimore Beltway, okay? All right, so think about, we all know that the heart is, the cells of the heart are stupid, okay? They just sit there and they wait for an electrical impulse to pass over them, and when they do, that means contract, right? They don't care where that signal comes from, how frequently it happens. Electrical impulse means contract, okay? And that's obviously the contraction, the contraction is important because that's what causes blood flow, okay? So typically, as we know, the signal comes from the sinus node, and then top chambers contract, and then it goes through the AV node, and then the bottom chambers contract, okay? What happens in AV NRT, imagine a car that starts in Philadelphia, somewhere up here, okay? That's the sinus node. As the car drives down 95 south, okay, it gets to the Beltway, okay? The process of the time it gets from Philadelphia to the Beltway, that's when the top chambers contract, okay? When it gets to the Beltway, that's the AV node, okay? 80% of the population is born with not a complete Beltway, okay? The car can only go one way or the other. It can only go towards Towson or towards Essex, all right? Most of us don't have the ability to go both ways, okay? But 20% of us can, okay? So imagine a car starts in Philadelphia, gets to the Beltway. It hits traffic going towards Towson, okay? So it decides, I'll go towards Essex, okay? Goes around the Beltway, gets to 95 south, sends a signal down to DC, which is like the bottom chambers, and they contract. But it says, oh, look at that. The Beltway going up towards Towson is open. There's no cars over here. So the signal goes back up towards Towson, okay? All right? Gets to 95 north, sends a signal backwards, sends a signal backwards up to the atrium, okay? And that's why you see that small ditzel at the end of the QRS right here, this little guy here. So what happens is the signal went down to DC and then started coming back up around, and you see this small little ditzel, okay? Goes up, and then it just keeps going around in this endless loop, sending signals off to the top and bottom chambers, okay? When you give them adenosine, okay, what you're doing is you're adding so much traffic to this highway, you're slowing or preventing the car from driving around the Beltway, okay, and it terminates, okay? But you haven't fixed them, okay? In the right situation, you know, this can reinitiate and can come back, okay? So that's why it's not curative, it's just putting enough traffic into the system to prevent this signal from continuing to go around, okay? So what I do, and what I can do in the EP laboratory, is I can do an ablation, okay, and I can cure people of AV-NRT, and the way I do it is I put my catheter over here where the key bridge is, okay, and I blow up the key bridge, okay? All right? But I do it electrically, so I put a catheter into the heart, I know where this area is, and I burn this region. So essentially, I convert these people who have two ways to get around to only one way, because this way they can't go anymore, okay? So that's how we ablate it, that's how adenosine works, okay? So remember that little thing, that little ditzel at the end. Okay, on to the next thing. What do you guys see here? AV-NRT, AFib, flutter, WPW, or atrial tachycardia?
No, because you have the
Flutter. So 50-50. All right. Someone who says this is flutter, explain to me why. Yeah, so you see that nice sawtooth pattern for sure. All right. One thing to think about is it regular or irregular? Irregular. So generally, flutter is regular, although it is not always. Okay. So when it's really irregular, think more about fib than flutter. One thing you always want to look at when you think something is atrial flutter is the flutter wave, the sawtooth, will look identical in every single. The sawtooth looks identical as you go across the whole way. Okay? What do you see here? Yep. So this is fib. This is just what we call coarse atrial fibrillation. Okay? This is not atrial flutter. Okay? So it's really important to review the entire strip. Okay. What about this one? What do you want to do with this patient? Start him on Coumadin? Do an atrial flutter ablation? An atrial fibrillation ablation? Or just keep drinking your coffee? So what do you guys see? Same thing always. Is it narrow or wide? Narrow. Is it regular or irregular? Okay. Are there P waves? What's this? I don't know. Are those T waves, P waves? It's irregular. Okay, so in generally, it's probably not flutter because flutter is usually regular. Looks to me like there's P waves here. I mean, what else could that be? That's got to, this is the T wave. That's got to be a P wave. There's the T wave, so that's probably a P wave. Okay, so it's not atrial fibrillation. So does anyone know a narrow complex tachycardia that's irregular that has P waves? What? Who said that? Someone said it over there. No. MAT. That's right. Oh, yes. All right. So this is MAT, multifocal atrial tachycardia. Okay. You don't see this too often. Okay. Have you guys seen this before? MAT? You guys ever? No. No MAT. Yeah. Ah, there you go. So what MAT is? Imagine that different portions of the atria are firing and sending signals to depolarize the atrium. Essentially, you have P waves that instead of it coming from the sinus node, they're coming from different places of the atrium. And what you get is you get P waves that look different. Okay? So that P wave looks different than that one. That one looks different than that one. And this one looks different than that one. So the finding is you see 3 different P waves. And it's going to be irregular because it's coming from different areas of the heart. Okay? The patients you're going to see this in are patients with COPD. You see this in pulmonary disease. Okay? And the treatment for this is not beta blockers. It's not treat the rhythm. It's treat the underlying cause. So treat the COPD, and this gets better. Okay. Same concept. The difference between wandering... Yeah, no, it is. So wandering atrial pacemaker and MAT are the same. The difference is the T. Okay, so MAT, the T stands for tachycardia. So if the rate is greater than 100, it's MAT. If the rate's less than 100, it's just a wandering atrial pacemaker. But the concept is the same. It's P waves coming from different areas of the heart. Okay, how about this one? Flutter? All right, so here, remember that what that other one looked like. Every single flutter wave looks virtually identical. This one looks different because you have the T wave from the QRS. So these sometimes look different. But in general, when you go across, there's not much variability. They all will look the same. Okay? And the QRS is, and it's pretty regular. How about this one? So same thing. There's things you can certainly rule out here just by looking at it. Is it regular or irregular? Regular. So it's not atrial fibrillation, right? You don't see that little pseudo thing in V1 or in any of the leads. So it's probably not AVNRT, all right? It's not wide, so it's not WPW. So you're left with atrial flutter or atrial tachycardia, okay? And this one is really hard. So this is, I always have the most difficulty making a diagnosis when it's at a rate of about 150. And is this atrial tachycardia? So this is a P wave going to this QRS, P wave going to this QRS? Or is this atrial flutter? So P wave there, P wave there, P wave there, 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 there. And it's hard. So sometimes when we can't figure it out, this is the time to, in the ER, we would give adenosine, okay? And adenosine would give you the diagnosis, okay? If you give adenosine and you make these QRSs come less frequently because they can't get through the AV node and it's flutter, you'll just see the flutter waves going straight through, okay? And then it's a clear diagnosis, all right? This is atrial flutter. All right, so this is atrial flutter and this is atrial flutter. They just look a little bit different, okay? Uh-oh. Oh, that's not good. All right, so where we left off, we were talking about atrial flutter, okay? So remember how we saw atrial flutter? It looked different in two different pictures. One time it looked like the classic sawtooth, and then the prior one, or the one after that, it looked different. And what atrial flutter is, it's that same concept. It's that same concept of as when we talked about AV-NRT. Okay, it's always that re-entry phenomena. Think about the car driving around the beltway, sending signals off as it goes around. Okay. For atrial flutter, that can occur anywhere, okay? Anywhere that there's scar in the atrium, you can develop atrial flutter, okay? So if someone's had prior heart surgery, okay, where the incisions are, where they entered the heart, that now has an area of scar, okay? And those areas of scar enable the right environment to induce these atrial flutters, okay? The most common kind, that kind we see with the sawtooth, which I get really excited about, involves the tricuspid valve. And I have a nice video, but I think that's what caused the thing to fail, so I'm not going to show it. But essentially, think of the electrical signal going around the tricuspid valve. Here's the right atrium, here's the right ventricle. So signal going around and around. As it gets to a certain location, it depolarizes the top chambers. When it gets to a different spot, it sends a signal off to the bottom chambers. Okay? And the reason I like atrial flutter so much is because it's very easy to ablate. Okay? I can bring people into the EP laboratory, put a catheter through the vein in their leg, up through the inferior vena cava, into the right atrium, and I burn a small lesion from here to here. This really doesn't do it justice, but same thing as blowing up the key bridge. I prevent the electrical signal or the highway from occurring. All right. And this is what it looks like when I'm in the EP laboratory. These are two views of the heart. Okay, this is looking at the heart directly on, so from this direction, and the other one is looking at it from the side. Unfortunately, it doesn't look like this. It would be a lot easier if it looked like this, but this